Hello, everyone, and welcome to this next episode of the Akkad and Koka Report. I'm Michel Akkad in San Francisco, and with me is my co-host Anish Koka in Philadelphia. As always, you will be able to find links to the documents and items we discussed during the episode on our show notes at akkadandkoka.com. And if you find our show informative and engaging, please subscribe to it on your favorite podcast app or on our YouTube channel. And if you could rate us on iTunes, we would greatly appreciate it as well. Our topic today is coronary heart disease, one of the most common forms of cardiovascular disease affecting men and women in developed countries, yet one that remains shrouded in mystery as to its causes and natural history. Our guest, who will help us shed light on the matter, is a medical sociologist and historian. Dr. William Rothstein is Professor Emeritus of Sociology at the University of Maryland. He is an accomplished scholar who holds a Bachelor of Science from MIT and a PhD from Cornell University. He is the author of several peer-reviewed books, including American Physicians in the 19th Century, From Sect to Science, published in 1972, American Medical Schools and the Practice of Medicine, A History, published in 1987, Public Health and the Risk Factor, A History of an Uneven Medical Revolution, published in 2003, and most recently, The Coronary Heart Disease Pandemic of the 20th Century, Emergence and Decline in Advanced Countries, published this year by CRC Press. Bill, welcome to the show.
Thank you. It's a pleasure to be here.
We're delighted to have you. And before I turn it over to you to tell us about your book, I would like to actually talk myself a little bit and give my intellectual journey that led me to discover your work, because I think in doing so, it will provide the audience with a helpful context for a discussion about your book. So let me start by first saying that when I was in actually in residency in Houston, I trained at the University of Texas. I did my internal medicine residency there. I had the immense privilege of learning under Herbert Fred, who became my mentor and remains my mentor to this day. I'm still in touch with him. He just retired a year ago, but he was my teacher there. He is, I consider him to be a giant of medical education, and he is recognized as such. And at the time, he has an encyclopedic knowledge of disease, but he is very, very keenly in tune with the natural history of each disease and the way things present and manifest. And he was really not interested in therapies and interventions, because for him, the most important thing was to have an understanding of how disease develops in each person and the various presentations that it may have. And he was able to teach us, principles of clinical evaluation that incorporated that knowledge to the extent that we could have it. But he lamented the fact that in our current practice of medicine, we are so keen on intervening immediately from the get-go on any minor abnormality. And it would infuriate him, for example, when as residents, our pager would go off, and it would, typically be a nurse calling us and saying, doctor or intern, whatever, patient so-and-so, blood pressure is 160, or, a little bit elevated. And then we would immediately jump and give an order to treat the blood pressure to reduce it. And it drove him mad, because it reflected such a poor understanding of the natural history of things. I mean, he was not a therapeutic nihilist, but he wanted us to think about things before we acted. So that stayed with me for a long time. His appreciation, he sensitized me to the importance of the natural history of condition and diseases. Then I left Houston and I came to San Francisco to do my cardiology fellowship at UCSF. And I worked in a basic science laboratory, and my work was successful. I was working with mice models. They were genetically modified mice. It was very, very much in fashion at the time. We're talking here about the late 1990s. Modeling, they were engineered to have severe disorders of cholesterol metabolism, and they would develop atherosclerotic plaque. So I had, mutant mice, and I was, characterizing them and that sort of thing. And it was very successful. But at the same time, I knew, in my heart that we were not learning anything of any relevance to human beings and to what coronary disease in real patients is about. I mean, it was really a very artificial model. And I had at the time I had the chance to read about coronary disease. I was interested in it, and I knew that it had, a very strong environmental component or a component that, could not simply be genetic, just because I knew that it had sort of become very common at some point in the 20th century and that sort of thing. And so my research, was successful, but I knew it. It seemed to me that it was not really relevant, and there was something missing to our understanding of coronary disease, and I was a little bit skeptical of what I was hearing from the mainstream. At some point, we had the visit in our laboratory of a professor of medicine who was very, very prominent at the time, Scott Grundy. He was essentially Mr. Cholesterol, if you will, succeeding Ansel Keys. Scott Grundy was president of the AHA at some point, a very important guy. And I wanted to chat with him, and I chatted with him about, the French paradox, which I think people are familiar with. It's this notion that the French, seems to have a relatively low rate of coronary disease, despite the fact that their diet seems to be rich in saturated fat and so forth. So they seem to be contrary to the dogma. And one of the explanations was the red wine hypothesis, that maybe red wine was protective. And to me, I thought, I lived in France when I was in high school, and I thought that perhaps an alternative explanation, at least that one that amused me, was that the French paradox could be explained not by the red wine, which other countries drink wine and so forth, but maybe it was explained by the French cheeses, which is really particular to France. I mean, they have these cheeses with a lot of molds and things like that, and I thought, maybe that's an explanation for the French paradox, and I bounced that idea off of Scott Grundy, and he dismissed it immediately. He said, no. And in fact, he even dismissed the existence of the French paradox. And he said, that the French, if you look at it, the ones that eat more saturated fat have more coronary disease. And so he was sticking to the party line, so to speak. But I was not, too satisfied with his explanation. Later in my clinical training, I attended a lecture by another academic cardiologist, David Faxon, who briefly mentioned in the lecture that he gave, it was on coronary disease, he briefly mentioned the Maasai of Africa. I don't know if you know about the Maasai of Africa, but they're a tribe in Kenya that has been was described in the 1960s because they have a diet very rich in saturated fat. They eat essentially most of the year, their diet is the milk from the cow that they herd, they're herders, and it's very, very fatty milk, 6% saturated fat milk, and then the rest of the time they eat meat. So their diet is very high in saturated fat, yet their coronary mortality is very, very low. And that struck me as being, interesting. And after when I was completing my fellowship, I got in touch with George Mann, who by then had retired, and George V. Mann was one of the early Framingham investigators who left the Framingham group early on and then went to Africa, and he was the one who had worked on the Maasai, or at least he was among the ones who had worked on the Maasai. And we had a nice exchange of emails at the time, but nothing came of it from my perspective because I left academia. I finished my fellowship and I decided to go into regular clinical practice, and I didn't pursue any scholarly work at the time. But I started practicing medicine, and then when I practiced medicine in different contexts, I was, like many doctors, kind of annoyed, and I was unprepared in my clinical training, unprepared by to the fact that medicine is practiced in such a assembly line, industrial process, and that kind of bothered me. And not only that, but it seemed to me that the science that we were getting from the academic centers about how to treat various things, whether it's hypertension or coronary disease or cholesterol or whatnot, really was a science that was itself conducive for this kind of population-based approach where the individuals are blended into a bigger mass of people according to risk factors and that sort of thing. And that, sort of interested me. And I started to write. I started to blog. Essentially, I started a blog and I started writing some reflections on all these considerations that I was encountering, having to do with how we managed risk factors, and that was very much a departure from what I had been sensitized to by Dr. Fred when I was a trainee, with his careful attention to the natural history of things. So I was writing, reading and writing blog posts and so forth. And then at some point, after I had collected a series of blog posts, I went to Houston one time and I met with my old mentor, and I shared with him some of these things that I was writing. And he told me, he said, these are interesting. We should try to publish them to, perhaps I can help you. He's a fantastic writer. And he taught me, and he continues to teach me how to write. And so he said, why don't we write a few of these things together and submit them for, maybe at little pieces in medical journals. And we did. We published a few things on hypertension, on the use of statin for cholesterol management, that sort of thing. And then at some point I wanted to write about the concept of the risk factor, which to me was, I could recognize that it had become a very, very pervasive and important idea in medicine that seemed to be coming out of nowhere. But it was dominating our entire thinking. Everything was about risk factors and how to manage risk factors and that sort of thing. And risk factors to me had little to do with the natural history of diseases and so forth. So I wanted to write an editorial with Herb Fred, but what I wanted to see what had been written about the concept of the risk factor, and I couldn't find it in the medical literature because all the papers talked about risk factors without taking it for granted, and there was no getting to the bottom of where that concept emerged from. So I went to the UCSF library. And I went to their book catalog and said, perhaps there's a book that just talks about risk factors. So I put the key words, risk factors, and there's only one book that came up, and that was your book, Bill. So that's what brought me to you. It's your book from 2003, which is entitled Public Health and the Risk Factor, The History of an Uneven Medical Revolution. So I knew immediately that was what I was looking for. And your book, I looked it up, and I read it, and I found it fantastic, and I cited it in my little editorial that I wrote on risk factors. And your book was very well reviewed in the New England Journal of Medicine at the time. And it has really, it's an outstanding work. And I think we'll be talking about that shortly when I turn over the microphone to you. But basically, this is my story that led me to you. And then now Anish and I launched this podcast, and I thought I would invite you. And so I sent you an email, and you kindly replied. And then you told me that you had just published this other book on the Coronary Heart Disease Pandemic, which is, fantastic. And we're very delighted that you've done that. And so here we are. So I'm sorry about, taking so much of the time before I let you speak, Bill, but I wanted to give a little bit of the context here to the audience about our relationship. And so, Bill, you've written this book on the pandemic of coronary disease, and I think you have an alternative view. So you've researched carefully. It's a very methodical book. You go to primary sources of the epidemic of coronary disease. And what do you want to tell us about it? So can you start with a little, a few minutes to tell us what the main thesis of your book is?
All right, first I want to say that my campus is the University of Maryland, Baltimore County. Like the University of California, there are a number of campuses in Maryland. And I want to just make clear that that's mine. Now, I want to start by saying how I got interested in the risk factor very briefly. A friend of mine, I just work on the history of the medical profession. That was my main interest. And somebody, had written a book about the role of the life insurance industry in medicine. And I thought that's a very interesting subject. Because early in the century, life insurance companies employed physicians to examine applicants for policy. So there was a lot of knowledge going from the life insurance industry to the average physician in the street, not just classes. Because I suspect that in the first half of the century, practically every physician that's a young man had worked for a life insurance company at some time, just to pick up a few bucks. And as I got into it, I discovered that they discovered the risk factor, and they told their life insurance examiners, look, when you examine a policy of an applicant for a policy, you tell us his blood pressure, you tell us his build, you tell us. And that's how physicians learned about risk factors in medicine.
That's amazing. That's in you describe this in your book on the risk factor from 2003, and we'll link to that book on our show notes. But this is really amazing because I don't think people realize that you're absolutely right, that it is the life insurance companies that even taught doctors how to take the blood pressure. When the first blood pressure, sphygmomanometers were invented, there was no interest in the medical community about having one in their clinic because they didn't know what to do about it. So it's really the life insurance industry that taught doctors how to measure the blood pressure on a large scale.
And in the meetings of the medical directors of life insurance companies, one medical director said, we're going to have every physician take blood pressure readings to teach them how to do it. That's how primitive it was in the medical profession.
Correct. And the life insurance industry settled the question about whether a high blood pressure is beneficial or harmful, because that was controversial in medical circles, since the late 19th century, and people had, very strong opinions one way or another, but they couldn't settle the question, and it required the accumulation of a lot of data and long-term follow-up, which is what the life insurance industry did for its own business purposes.
Right.
They collected
However, the only thing they didn't do, they were not interested in a level that you would call hypertension. They were interested in the gradient, all right, because they were not dealing with individual policyholders. And the higher, the worse. That was their attitude. And so if you read the early literature, including the medical literature, on high blood pressure, they do not specify a level that's hypertension. That took a long time to work out.
Do you know if they essentially adjusted the premiums in a graded fashion? So the higher the blood pressure, the higher the premium would be, that sort of thing?
Well, you have to realize the life insurance company does not want to deny you a policy.
Right.
If they can, they'd like you to buy a policy at a higher premium.
Mm-hmm.
So all these risk factors were put into formulas in which they elevated the premium depending on the level of your risk factors. And from your perspective as a policy, at least you got a policy, right?
Right.
So they were thinking of gradients, never as dichotomies here.
Right. Unlike the medical community, at least the public health, the medical community, to the extent that it's acting in a public health capacity where they want doctors to act based on a certain threshold and that sort of thing.
Right.
Yeah.
Well, the first studies of medication for high blood pressure in America were done at Veterans Administration hospitals. And they identified people with that they call malignant hypertension. Mm-hmm. And they had extremely high mortality rates. And they benefited immediately from antihypertensive medication. Right. So really that was the great change. It was these malignant hypertension people, because it was so easy to see that they hadn't dropped dead in 2 years as you would have expected them to do.
Right. Good. So,
by the way,
yeah, go ahead.
He did not have a high opinion of physicians, the guy who did that study.
You're talking about the medical director of the
Well, he was a physician with the VA, and
Oh, I
he
see. I
said,
see.
right, and he said that given how bad the therapies were before anti-hyper medication, the best physicians did absolutely nothing about it.
Right. Right. So Bill, so you got interested in the risk factor from that angle because you were sensitized to the influence of the life insurance industry on medical practice, which, as a sociologist, was something of interest to you. And your book, which is that first book on the risk factor, is just fantastic. I mean, it's a big historical book. But what I remember getting out of it, at least there was one nugget in there that really caught my attention, and that I used in my in the editorial that Herb Fred and I wrote in 2010 about risk factors, was that when you examine the records of the life insurance industry, you see that there's a decline in the coronary disease mortality even before the risk factors start to catch the awareness of the medical community, which really happens in the late 1950s with the Framingham investigators and that sort of thing. And it seems that strand of thought in that first book you develop it more in your current book, which is really on the coronary heart disease pandemic. Is that fair?
Yes, I would just say though that some of the people on the Framingham study, the original one, had worked for the life insurance industry, and they were the ones who brought the risk factor into the Framingham study.
Correct. The concept of it, for sure. That's right. Exactly right. So tell us. I'm sorry. Go ahead.
So that when I saw, as you described, that there was a real curve in CHD mortality, of course, I had to pursue that issue further, and that's what led to the newest book.
Okay. Tell us about this new book, the Coronary Heart Disease Pandemic, and use the term pandemic and not epidemic, and I think that's important in the book.
All right. Now, I'm just going to describe my evidence that it was a pandemic. I'm not going to talk about causes or implications. Mm-hmm. We can talk about that later. Mm-hmm. So the first thing I did was to try and find out what the characteristics were of pandemics generally. And I found nothing in epidemiology textbooks. And looking at them, I decided there were three characteristics. One is a rapid rise and fall of mortality rates in multiple countries. Two, and some population groups experience greater increases and decreases than other groups. And third, there are geographic variations in mortality in every pandemic. Going back to the great Black Plague pandemic, they noticed geographic variations then. All right, so applying that to coronary heart disease, if you take the rise and fall in mortality rates, they rose in the 30s and 40s in the US, Canada, Western Europe, Australia, New Zealand, peaked in the 50s and 60s, and have decreased in every one of these countries after about 1970. Every one of them, without exception. Mm-hmm. And the famous Monica study found that the decrease was almost very largely fewer new cases of the disease, not higher survival rates of those with the disease. Second, the population groups most affected. And in every country, there are greater increases in mortality rates among men than women during the rise of the pandemic, greater decreases in mortality rates among men than women in the decline of the pandemic. Geographic variations. If you look by continent, the peak mortality rates were higher in the US and Canada and lower in Western Europe. The peak period in the US and Canada was 50 to 70. The peak period in Europe was 50 to 80. Within continents, in the US, the peak rates were highest in New England and the mid-Atlantic states. There was no area with the lowest rates, just enormous sections of the country. Mm-hmm. In Europe, the peak mortality rates were highest in Northern Europe, the lowest in Southern Europe. And there are four countries that had similarly low rates: France, Switzerland, Spain, and Italy. And they talk about this French stuff all the time, but in fact, Switzerland had the same pattern of the pandemic as France. Now, the countries that did not experience the pandemic, somebody did a very nice study of Latin America, the largest countries in Latin America, around 1990, 2000, and there was no evidence of pandemic. Eastern Europe, I looked at WHO data for Eastern Europe and the former Soviet republics. I could find no evidence of one, but a good friend claims that you cannot trust those data. And so he couldn't say one or the other.
Mm-hmm.
I couldn't find data for Africa or Asia, so I couldn't say anything about that.
Okay.
And that's the pandemic.
So pandemic, rapid rise and rapid decline in mortality, a difference in who's affected. But
Right.
but when you say rapid rise and rapid decline, we're still talking about compared to a context of background incidents before the pandemic and then after the pandemic. Is that right? So
That's correct.
So coronary disease has been described. Angina was described in the 17th century or 18th century, and it's existed. And we have Egyptian mummies that have evidence of atherosclerosis and that sort of thing. So it's not something completely new. But what was new was this just rapid, sort of massive rise. And what you seem to say is a relatively rapid decline also of incidence of coronary disease, with a some peculiarities in that the pandemic affected men more than women, and then certain geographic areas were affected and others seem to be spared.
I would say, I think the geographic aspect is the best evidence for a pandemic, because all pandemics tend to be geographic. They just don't occur. If it occurred to an equal extent in every country of the world, you should say to me, you got to be kidding. That could never happen.
Right.
So I like the geographic dimension as showing that there was a cause, and the cause was more severe in some parts of the world than others, right?
Okay.
So, Dr. Rothstein, could you enlighten us on what the I mean, you're taking great pains to say that this was a pandemic. What is the prognostic importance of getting that right, whether it's a pandemic or not?
Well, the question is, for example, the statins, which are used for primary prevention. The statins became popular 30 years after the decline of the pandemic began. Okay?
Mm-hmm.
Well, that raises real doubts in my mind as to whether, as in primary prevention, it's of any value. Then to take another example, everybody talks about diet and coronary heart disease. I cannot believe all those countries changed their diets in the same way to cause the rise of the pandemic, and change their diets in the same way to cause the decline of the pandemic. It's just inconceivable.
Right. So let's develop that point a little bit. So the pandemic begins in the 1920s and 30s.
Well, 30s and 40s.
The 30s and 40s.
Right.
Okay. And the usual explanation that I remember, is, well, by then, the most common cause of death was infectious disease. By then, tuberculosis was on the decline, and so forth. And it's sort of a natural new stage. You have, of being a rich country. In a rich country, then you have, pandemics of coronary disease. Coronary disease emerging as the illness of being rich, right? Now it's that doesn't hold if you actually think of it as a pandemic. Would you say that's correct?
What are you going to do about the decline? There's no evidence of reversals in any of these factors in a rich country that could possibly explain the decline. I want to give you just one more piece of data to show you how severe it was. I have percentage of all deaths caused by coronary heart disease for white men 55-64. In 1940, 15% of all deaths were due to coronary heart disease. 1960, and this is 1970, 41% were due to coronary heart disease. 2010, 18% were due to coronary heart disease.
Okay.
If you look at white men 65-74, it's exactly the same. Now that's an unbelievably dramatic increase and decrease in percentage of deaths from coronary heart disease. And you can see why physicians in 1950 and 60 were so horrified at what was going on, right?
Right. I guess there's a lot of, there are a fair number of, there's so many confounders there, meaning how do you, why is it not possible that, how do you not correlate this with, say, a wider understanding that smoking was bad, and that overall the rates of smoking amongst a certain demographic started to go down, or the fact that exercise started to get, much more in vogue starting from the 70s or 80s, whatnot, or the fact that stents came out. You had stents that may have impact. The stents being used for primary MI, helping to reduce the mortality for folks with coronary disease. Now, all of these things didn't come out at the exact same time. But I just off the top of the head listed 3 or 4.
Well, let me take 2 of them.
Mm-hmm.
One is, I told you that the evidence is it's fewer new cases, not longer survival rates of people with the disease, so the stents could not have been a major factor. Second, smoking rates in the U.S. began to decline after 19. What I did was use lung cancer mortality rates, okay, as evidence of the effects of smoking. And lung cancer mortality rates in the U.S. began to decline after 1990, 20 years after the beginning of the decline in coronary heart disease mortality rates. 20 years is a long time.
Yeah. Mm-hmm. Of course, maybe the mortality declined. How does that relate to whether, use of chemotherapy for lung cancer? Meaning, you see that,
but if you look at smoking,
mm-hmm.
cigarette smoking per year, it was in the late 1980s that the number of cigarettes per person began to decrease.
Right.
So you're showing, I think, in certain subgroups in that mortality peaks for coronary disease in certain subgroups, even in the 1950s. Is that correct?
No. No. Actually, it was the other way around. If you look at blacks in the U.S., they had lower mortality rates than whites in 1950, and they increased more in 1970 than the whites did. The pandemic occurred somewhat later for the blacks in the U.S. than it did.
One other question. So there's a bunch of different things that happen that are a bunch of different confounders, of course, that always complicate trying to figure out, trying to get away from correlation to cause. But what about are you moved by the you'd mentioned statins, and are you moved by by their use in the folks with familial hypercholesterolemia? In terms of the pathogenesis of serum cholesterol, how that serum cholesterol got there and how it relates to diet is, of course, quite is a link that, of course, seems to be quite a moving target. But regardless, it would seem like having very high levels of serum cholesterol seems to result in plaque deposition. That link appears to be true in folks that have familial hypercholesterolemia. You brought up the point that, well, how do we know whether statins may be effective for primary prevention? Are you saying that it's not believable, or there isn't enough evidence to suggest that folks with high levels of serum cholesterol are at higher risk for atherosclerotic plaque formation?
No, I think everybody agrees that statins are very useful in secondary prevention. And there was a study that just came out this week, either JAMA or the New England Journal, that looked at statins in diabetics and people with without diabetes, and they found that the statins were beneficial in people with diabetes, but not in people who didn't have the problem.
Yeah.
So
I guess one of the largest meta-analyses, or one of the groups that puts out this stuff is the Cholesterol Trialists Collaboration, the CTT group. And it would appear to be that even for primary prevention, you do see a drop in cardiovascular events. Now it's not as big of a drop, so it's much larger trials, pooling. You've got to pooled very large numbers of folks to show it, but certainly it looks like, except for patients that are on dialysis, outside of that, the relative risk reductions for cardiovascular event reduction there seems to be one for folks who haven't had an event yet. And how does that make sense anyway? Meaning obviously there's some group of us that are sitting around. There's some folks that ultimately who one day don't have a heart attack, the next day have a heart attack. Does it stand to reason that if we figured out who that person was, that we could treat that individual the day, obviously not the day before they had the heart attack, but if we could identify these groups of people that are going to have a heart attack, that treating them with statins would be beneficial?
All right, this is the great debate between the life insurance approach and the clinical medicine approach, right?
Yeah.
The life insurance company ought to give a damn which of their policies holder by name. It's the number who die that they're interested in, right?
Right.
They take a probabilistic approach to the whole thing. And the poor clinician has to be concerned with individual patients, right?
Right.
Now, the other thing is that if mortality rates began to decline in the U.S. in 1970, let's say, and we say risk factors were important, they had to start declining in around 55 or 60, right? To produce a decline in mortality rates in 1970.
Yeah, but right. No, that's true.
Yeah,
but
I think that's right. That's
it's a good point. But what about the latency of if the ills of tobacco started to become obvious in the 1960s? I don't know when exactly they became obvious, but there's some time period. It's not that the moment you stop smoking, you're going to have mortality reduction, CV events. It's probably going to take 5, 10, 15 years. I think. The single biggest thing we've done in terms of highest yield thing we've done in terms of reducing cardiovascular mortality, clearly to me seems to be stents in people that are having a heart attack, where you have, over and over again. And Michel does this when he's on call. He takes 50-year-olds that are about to die, and he.
Yeah, but I think we need to clarify something here, Anish, because that's not. I don't think Bill is implying that the stents don't reduce mortality.
No. I'm saying that Grunsig was 1970. What was that? 1978 or something like that. The
first angioplasty.
Right. That was angioplasty for stable angina, and then I think the first time it started to get used was in the early 1980s, and clearly that seems like used, scaling that to having a cath lab within 90 minutes anywhere in the United States or in advanced countries would see. It seems hard to believe that has not had any reduction. That has not resulted in a reduction in overall CV mortality. So when we see that beautiful trend line that we see from the CDC in terms of declining cardiovascular mortality.
I disagree, Anish, because I think if you look at the trend lines, they're very monotonous. The decline in mortality is very, very monotonous, and you don't see at some point sort of a sharp drop, a further drop in decline with, for example, the introduction of statins or with the introduction of angioplasty and that sort of thing. If you look at the trends in general, correct me, Bill, if I'm wrong, but it seems that the decline. Now, of course, you have you have to stratify by age and that sort of thing, and now the population is much older now than it was 30 years ago or 40 years ago. So there's that factor. I think what Bill is pointing to is the fact that there was there was some background coronary disease in the 19th century and early 20th century. All of a sudden, it became very, very rapid, extremely prevalent in relatively younger people, and men more than women, and that prevalence increased in a bunch of countries at the same time. A whole bunch of countries very far. And it's hard to explain this according to, the traditional explanations of lifestyle and that sort of thing. That it's. I mean, that's. I'm not saying that's. So the two are not incompatible. I mean, of course, on a given patient, doing a stent in somebody in the midst of a heart attack can deflect the mortality of that person, but that doesn't contradict. I think what Bill's observation is that the decline in coronary mortality either coincides or maybe sometimes even precedes the decline in the most commonly acknowledged risk factors.
I agree. Well, let me give you what coronary heart disease is like today.
Yeah.
If you take the percentage of all coronary heart disease, ischemic heart disease deaths at age 75 or over, okay, in 2010, among white men, 56% occurred to people ages 75 and over. Among white women, 79% occurred to people ages 75 or over, slightly lower rates for the black. And if you take 85 and over, this is just unbelievable. Among white men, 29% of coronary heart disease deaths occurred to men 85 and over. Among women, 53% occur to women ages 85 and over. Half of all coronary heart disease deaths of white women are at ages 85 and older. I don't think that's a public health crisis, in my opinion.
Yeah. So correct. I agree with you. And it seems to be. I mean, I think what I would say is that we're dealing with a different beast right now when we're dealing with our run-of-the-mill coronary disease today in 2018. It's not necessarily the same as what what was happening back in the 20th century in the.
Dr. Rothstein, I think you've written. Tell us in your own words. What do you think was behind the rise?
I think the pandemic had a different cause than coronary heart disease in normal times. What the cause was, I have no idea. But it spread around the world at the same time. I think that's the crucial part. It didn't occur 30 years later in France than it did in America. It's the same time. Declined around the same time in all these countries. So it says to me, it has to be the same cause everywhere, and something happened to modify that cause.
Right.
Now, the interesting thing would be, is it popping up somewhere else, right? And I showed you, this guy did this excellent study of the largest countries in Latin America in around 2000. And if it was popping up somewhere else, I would suspect that you see an increase in Latin American coronary heart disease deaths at the turn of the 21st century. That did not happen.
Well, the public health guys will claim this as a victory.
Right.
They cured the pandemic with the food pyramid, obviously. The one where we're supposed to eat lots of cereal.
It's interesting, and to that point, I mean, the another risk factors we hear about a lot now is diabetes and obesity, and obesity rates have risen since the 1980s, supposedly dramatic levels in our country.
That's my most enjoyable comment. Obesity levels are going up, and coronary heart disease mortality rates are going down.
Right. Yeah. Yeah, that's right. So that doesn't compute. Now the people will say, well, it's around the corner that we're going to have a massive influx of coronary disease, but we haven't seen it yet.
No.
Now, if it comes to be, if in 5 years there's all of a sudden a lot more, coronary disease mortality, perhaps we'll have to revisit. But I think that's an important point. And the truth
I think it's unlikely because the obesity rates have been rising for so long that their effect, in my opinion, should be appearing now.
By now, right.
Right.
Well,
Not
we can't not mention. There's always an answer from the public health folks. So we got to mention the obesity paradox that has been posited, right? That obesity may be protective.
The life insurance industry doesn't agree with that. And they have, hundreds of thousands of policyholders. We're not talking about these silly samples in the medical journals. And some of their studies have millions of policyholders. You got to believe that data.
Right. So, if I can put what Bill, what you're saying in perspective, is that in the 1930s and 40s, you have the beginning of this pandemic of coronary disease that really takes off in a major way, and then starts to decline in the 60s and 70s, and continues to decline. We as clinicians, have identified a few things, and we're doing them, and we think we're doing the right thing. And I'm not saying we shouldn't continue to do what we're doing, but we are doing all these things, and whether it's having any impact on the pandemic or not, it seems to be, a different question altogether. And perhaps it has an impact on, in certain cases on certain people. But there's sort of this parallel movement between what the pandemic is doing on its own, and we clearly don't fully understand it, because the causes and the risk factors that we use to explain that pandemic don't seem to, at least from a sequence perspective, it doesn't seem to match with the natural history of this pandemic. So the pandemic is proceeding, and here we are doing our own things, and we do, and and that's what's happening. On the other hand, except that perhaps one can make the point that we're wasting resources, and they should be redirected in a different way.
All right, now let me tell you, my argument is that we live in a world today of non-pandemic coronary heart disease rate. We're talking about 15% of deaths and you saw the age distribution. It was shocking. These are really old people. Right. Now, the problem was these risk factors were identified during the pandemic. Mm-hmm. So my argument is the risk factors are for a different disease than we have now.
Right. We do have, the pandemic is not complete. I would say the pandemic is maybe on it's the tail end of it, but I still do from time to time have, the occasional young man without, who's not a smoker, doesn't have a terrible cholesterol, seemingly reasonable diet, active and whatnot, who either drops dead or has a heart attack and that sort of thing.
Absolutely.
And so, but you're saying is that cases like this are sort of on the decline.
Right. Well, obviously.
Right. Yes.
If you look at the age distribution of deaths.
Right.
Well, it's going to be very hard as we move forward. We're so connected now that, as soon as one woman starts using jade eggs in California, the next day, some woman in France is also using jade eggs because of Instagram and Facebook and whatnot. So in terms of the idea that we're not all kind of walking in lockstep, and why should the United States be very similar to, France or Britain or whatnot? Certainly, as we get more and more connected, it seems like we will all either rise together or fall together. I don't know if that's good or bad.
Well, I want to go back though and talk about the unbelievably shoddy research that led to this emphasis on food. The original study on the effect of diet and coronary heart disease uses the Mediterranean diet. That used Spain and Italy as the evidence for the Mediterranean. Very good. But France and Switzerland had the same mortality rates as Spain and Italy. Now, you can't do that. If a graduate, an undergraduate
is not on the Mediterranean.
If an undergraduate student came in with a paper like that, I said, you got to get other countries. You can't just look at those two.
Right. And I think that's become clear, from the writings of many people in the last few years that whole lipid diet hypothesis was prematurely advanced. as an explanation for the coronary disease pandemic.
But the problem is that it seems like any nutritional any nutritional hypothesis is problematic.
I agree with you completely about that. The relationship between diet and, except for diabetes, I'm willing to take diabetes and sugar, okay? But I think it's just grossly over-exaggerated.
Right.
That diet.
Can I ask how you would suggest? So there's risk factor medicine, which I honestly I'm not entirely sure. How do we get beyond risk? Can you tell someone who's not as smart how we can get beyond risk factor medicine?
Well, the issue is disease theories have become probabilistic, right, rather than deterministic. And let me read you a quote, not that I wrote, but I cite in the last chapter of my risk factor book, and he says, here, the most vital contribution to the risk epidemic has come from the development of scientific thinking itself. Within this thinking, there's been a movement from a paradigm of monocausal determinism, that is bacteriology, towards a paradigm of multiple causes and effects, accepting uncertainty as a vital factor. And I think that's what the risk factor did.
Right.
But that's not my quote.
Correct, and you're right, and there's a lot of it puts the clinician in a conundrum as to what to do. But what's interesting also that I got from your book is that even infectious diseases, because you start your book by putting the question of pandemic in its broader context, and you use tuberculosis, lung cancer, coronary heart disease, and influenza, right, as examples of pandemics. But even the ones that are, in essence, monocausal, like influenza and tuberculosis, do have pandemics. So there are obviously other factors that influence, the rise and fall of these diseases. And tuberculosis was clearly on the decline way before we had antibiotics for it. And the usual explanations, just like for coronary disease, are not entirely satisfactory as to what caused the pandemic of tuberculosis, in terms of overcrowding and that sort of thing.
Well, I give some data there that agrees with that. I show that if you look at TB mortality rates in Massachusetts and England, they declined from 1850 to 1900. Okay, but infant mortality rates did not decline in either country. And our best evidence for the standard of living is infant mortality.
Right.
So the standard of living could not have caused a decrease in to TB mortality.
Right. So my take-home message from all this is that we should be very careful about jumping to conclusions and then proceeding with health policy, public health mandates that end up affecting the clinicians, because there's a lot of top-down directing of the actions of physicians to treat risk factors and to do this and to make such and such recommendations, as if we understood these pandemics. And it's very humbling that I think we really don't understand them very well. And I'm glad to see doubts being raised about all these preconceived notions that we have.
Skepticism is a beautiful thing, and not accepting whatever hype, wherever it comes from, is a great, wonderful thing. But it's somewhat similar to the climate change debate. Meaning it seems like regardless of whether or not we can predict the temperature 200 years from now or 300 years from now, and what exactly that temperature change will do to climate levels, and how we can make that with a tremendous amount of certainty, it just seems like it may be a bad idea to mine carbon that's finite and pump it into our atmosphere. Point being is that I don't necessarily have to have a deterministic model to know what exactly is going to happen if we take all of Earth's carbon and pump it into the atmosphere, to think that maybe we should do something to mitigate that. So the same thing happens when it comes to trying to tell these individuals sitting in front of me in the clinic what to do, and so if I still struggle to get beyond looking at the individual and saying, well, it seems like these are risky behaviors that you may
right,
want
but I think the way to deal with that, Anish, is that I think that in terms of it's healthy on other grounds to exercise. You don't have to invoke the change in coronary mortality to prescribe exercise.
No,
Same thing about cigarette smoking. It's healthy on other grounds, right?
But you're making my argument. Meaning it just seems like meaning we don't exactly know how smoking will affect cardiovascular mortality, but are we wrong to say that it could? And there's a chance if there's a chance that it could, that you should stop smoking, meaning or you're saying we should stop smoking because you don't want to kiss somebody who's, or I don't know, what are the other.
Smoking affects so many diseases that coronary heart disease is peanuts compared to all the cancers that are increased by lung smoking, right? And respiratory diseases and all the rest.
Right. Although, to me, it's hard to shake. I mean, I don't know. Sometimes, I mean, you do as a clinician, we see the occasional person with really extensive atherosclerosis.
Yeah.
He's just a chain smoker, and that's the only thing going with him or her. And it's hard for me not to put a cause to effect relationship. But at the same time, you're right that there are smokers who smoke a lot and don't have much, coronary disease.
Yeah,
I think I sent you, Bill, and I put that on Twitter. There was a review recently by Bill Roberts, who's the most prominent cardiac pathologist, who's now in his I think mid or late 80s, and who's had 50 years of experience, and he doesn't think that smoking is in the causal pathway towards atherosclerosis himself. But nevertheless, I mean,
who cares? It affects so many other diseases.
Correct. You're right. That's right. I mean, in terms of whether we recommend it or not, I mean, I don't think that matters. But in terms of the science of it, I think Bill is you make a point. I mean, I think we need to be humble, and public health is frequently not that humble. They're frequently almost mythical in what they claim that we know.
I agree completely. They just go overboard in their determination to provide recommendations. Now, take a lot. There have been a lot of studies showing that influenza immunization does not do any good. Mm-hmm. And so now I'm willing to buy it for nurses, and other people who are really in danger, but to immunize the whole world is just really unacceptable.
Right. For influenza.
Right.
Right. Yeah. There's this drive to do things on a massive scale, regardless of what the evidence is, to support that these kinds of positions. Bill, I think we need to wrap it up here. It's been really wonderful, very enlightening. I'm going to, again, the title of the book is The Coronary Heart Disease Pandemic in the 20th Century, Emergence and Decline in Advanced Countries. We'll put a link to it. It's available on Amazon, I take it, or?
Yes.
Okay. And thank you very much for joining us here.
Could you send me an email with the website and everything so I can access this?
Yes, definitely. And then if you have other links or documents you want to share, we'll put those on the show notes as well.
Okay. All right. I enjoyed this very much. It was a real pleasure. The conflict between the probabilistic and the deterministic theories of medicine just affected everything we've said, right?
Absolutely. Thank you very much, Bill.
All right. Bye now.
All right. Bye-bye.